We're going to look at an exercise testing case study right quick. This one is of a 69-year-old woman with a history of COPD. She seeks medical attention because of an increased dyspnea on exertion. Her medical history includes a smoking history of 40 pack years. She is currently using Singulair, Ceravent, and Pulmicort. Her primary care physician orders a pulmonary function test and a chest radiograph. The chest radiograph is normal. Looking at her lung volumes, if we start with our TLC, we see that it is about 114% of predicted. Now that's on the higher side, but we usually use 120% of predicted to tell us there's hyperinflation. Next, her vital capacity is relatively normal at 81%. Her residual volume and RV to TLC ratio are extremely elevated, and that suggests that she has some air trapping going on. So based on her lung volume so far, we expect some obstructive disease going on. So now moving on to our spirometry, we look at our FVC, and we see that that is 77% of predicted. Looking at her FEV1, that is 50% of predicted. Her FEV1 to FVC ratio is 59% of predicted. So we know that this is a moderate obstruction going on. Her FEF 25 to 75 is 15% of predicted. And then her FEF max is 94% of predicted. When we look at our post-bronchodilator, we do see our FEV1 does show a bronchodilator response, a pretty significant one. It increased by 25%. So we know this patient has moderate obstructive lung disease. Looking at our DLCO, we find that both the DLCO and once it's adjusted for hemoglobin are relatively similar, and they're both at 63% of predicted, which is low. So this suggests a parenchymal interference such as emphysema. When we look at the graphs from her exercise testing, starting with the picture on your left, you have minute ventilation here on the vertical axis and your VO2 on the horizontal axis. We see that our maximum voluntary ventilation is 44. It's showing you her breathing reserve right there. Her predicted VO2 max was 1.37 liters per minute. You notice she did not achieve that. Over on the graph on our right, we have the heart rate on the vertical axis with the VO2 on the right. Again, your VO2 predicted is 1.37 liters per minute, and it's marked with this line here, and obviously she did not get there. Her predicted max heart rate was 165, and we can see she did not achieve that either. Looking at her exercise results, we see that she had a workload of 70 watts, an overall time of 7 minutes. Oxygen consumption was 63% of predicted. Her R value was 0.95. When we consider her overall cardiac response, we saw that the heart rate increased to 153, which was not a predicted. It was 93% of her predicted max. Her blood pressure increased significantly to 225 over 105. So this is borderline exercise-induced hypertension. There were no abnormalities on our EKG, so we have no reason to suggest ischemic heart disease. Her oxygen pulse did increase with exercise, but not to the expected limit. So what this tells us so far is that we suspect that she's having a reduced stroke volume as a response to exercise, as we see with her shortness of breath limiting her overall outcome. When we look at her ventilatory response, we see her minute ventilation is about 70% of predicted. Respiratory rate was up to 30. Her tidal volume to vital capacity ratio does show that there's a slight reduction in our ventilatory reserve, but she does have an increase in her tidal volume to 56% of the vital capacity. So, so far looking so good. So let's look at our gases here. Okay, our blood gases before were 7.41. CO2 of 40, O2 of 66, O2 sat in 91, bicarb 25. So fairly normal. Looking at post-exercise, pH has dropped to 7.35, CO2 rose to 47, PO2 drops a little bit to 63, and our O2 sat dropped to 89. No change in our bicarb, which is exactly really what we would expect. So our arterial blood gases at rest show an increase in our AA gradient and an elevation in our VD to VT at 60%. Exercise blood gas show an increase in our PaCO2 consistent with ventilatory limitation and essentially no change in the AA gradient or the VD-VT. It also remains high at 52%. Oxygen consumption is moderately reduced, and it appears that the subject did not reach anaerobisis. So overall impression, when we look at the entire case as a whole here, we see a moderate reduction in exercise capacity. She has ventilatory limitation with exercise-induced hypercapnia. She has gas exchange abnormality at rest and with exercise, and then she also has exercise-induced hypertension. So how did we get here? So let's take a step back and walk through this again. So again, she did the 10-watt incremental protocol, and based on her predicted VO2 max of 1.368 liters, the subject terminated the test complaining of shortness of breath. So this appeared to be a maximal study based on her heart rate and ventilatory criteria. Her cardiovascular response showed an exercise-induced hypertension. Remember that blood pressure got to 225 or 150 or something crazy like that. Her oxygen pulse increased with exercise, but not at the level expected. It was a little reduced. So this suggests that she had a reduced stroke volume. Another possible explanation for the reduced O2 pulse is a defect in the oxygen extraction. O2 pulse is also directly related to the arteriovenous content difference. Her ventilatory reserve was reduced with an absolute difference of 13 liters, because there was 44 liters expected. However, her minute ventilation per maximum voluntary ventilation ratio is still within normal limits. This is an excellent example of how a subject with reduced maximal voluntary ventilation resulting from lung disease can have a normal ratio even though the overall ventilatory reserve is compromised. There should be an actual reserve of at least 10 to 15 liters between the maximal expected and the achieved ventilation. Her tidal volume increased proportionally with exercise to 56% of her vital capacity, so her breathing kinetics are appropriate. She does have a gas exchange abnormality, which we noticed originally with her DLCO, and at rest with an elevated VD-VT. Her gas exchange abnormality does not worsen with exercise. However, she does show progressive hypercapnia that is inappropriate during exercise and further supports that she is ventilation limited. Her VD-VT kinetics do not respond appropriately and stays essentially flat with exercise. So we knew she had a gas exchange problem just based off her DLCO alone, and then it was confirmed with her VD-VT, and then as she exercised, since that VD-VT didn't change and her CO2 rose, that all supports ventilation limited. So what happened to this patient? Well, she enrolled in pulmonary rehab. She did a 6-minute walk initially, and she got 1,047 feet. Her SpO2 on room air was 91%, and her rate of perceived exertion, or RPE, rated at a 17 out of a scale of 6 to 20. 6 weeks later, she retested, and her distance was 1,425 feet, so definite increase. Her SpO2 was 91% on room air, and her RPE was again 17 on a scale of 6 to 20.